Hey guys, a very warm welcome to my channel. This is Dr. Shubham, and today in this video I'm going to talk about the atrial septal defect. So if you guys remember, in the last video I had a talk about the ventricular septal defect or VSD. Today I'm going to just continuing that series of cardiology, and today I'm going to talk about the topic of the atrial septal defect or ASD. So let's try to understand what is ASD, right? So ASD is simply, as the name suggests itself, that there is a defect in the septum which is actually present between the left and right atria, right? It's a very simple definition. So what I'm writing over here is, it is a, first of all, it is a congenital defect, guys. So it is that congenital defect which will be having the which will be resulting in any kind of defect in between the atria, that is the left atrium, and the right atrium. So it is congenital defect which is resulting, right, which is resulting in an opening of interatrial septal defect or interatrial septum, right, of the heart. Okay, once we are aware of this definition, okay, just for the completion's sake I wrote this definition, otherwise you know the meaning, right? So there is a defect between this left and right atria. Now let me just explain it through the help of a diagram over here, right? Now you know that first of all, let's just talk about this diagram over here. So what I can see over here is that you can see, right, with the help of a cursor I will try to just explain this scenario over here, right? For example, as you can see that with the red color, right, this is one as you can see, one extension is coming downwards, and from here one extension is coming upwards, right? This extension which I'm calling over here is, that is called as the septum primum, right? That is called as the septum primum. And between the septum primum, I hope just you would be able to appreciate this opening between the septum primum, right? So this opening is called as the ostium secundum. Simple. Now you can see the another extension which is coming from the upward and then from the downward, and over here also there is a gap between these two extensions. First of all, what is this extension over here which I'm talking about? That is called as the septum secundum, and the opening between that will be called as the foramen ovale, very popularly called as foramen ovale, right? So till now we have a knowledge about that we are having a septum primum first of all, right? Then we are having a development of septum primum, and then we are having a development of septum secundum. The opening between the septum primum is called as the ostium secundum. The opening between the septum secundum is called as the foramen ovale, right? This is okay, this is physiological, this is just before the birth, right? This is before the birth. But now, okay, and before the birth, so what is happening, how the blood flow is happening? Look, in the adult everyone knows how the blood is flowing, right? I'm not going to explain that. But in the children, what is happening? I mean in the babies, in the babies in the intrauterine life I'm talking about, how the blood flow is happening. You know that umbilical vein will be carrying the blood into the, first of all, into the right atrium, then through this foramen ovale, right? This is physiological. This through this foramen ovale and this ostium secundum, the blood will be flowing into the left atrium, and then from the left atrium the blood will be flowing to the left ventricle, and then from the left ventricle the blood will flow to the aorta. Very simple. I'm just repeating once again. What I'm saying is, in the adult everybody knows that how the blood is flowing, right? But in the intrauterine life, how the babies will be having this particular circulation is through the umbilical vein. Oxygenated blood is coming, deoxygenated is not there. I'm talking about oxygenated. Oxygenated blood is coming through the umbilical veins. They will be actually giving the blood into the right atrium, through the from the right atrium through this foramen ovale and the ostium secundum. This blood will be coming into the left atrium, and then from the left atrium the blood can come into the left ventricle, and then from the left ventricle the blood can go into the aorta, into the systemic circulation. Simple. This was the oxygenated blood. Okay, no problem. Just after the birth, what will happen? As time passes by, this foramen ovale starts to close. This foramen ovale starts to close, right? First of all, it will be closing functionally, and then later on it will be closing anatomically as well. Then because what happens is, the lungs will be working now after the birth of the baby, right? Now the circulation will be like the adult one. But in some babies, let's say in some unfortunate babies, after even some point of time, right, let's say they are not having this closing of this foramen ovale, right? Usually this foramen ovale will be replaced by the fossa ovalis, but now let's say due to some reasons, right, this unfortunate baby was not having the the sealing of this or the closing of this foramen ovale. So now what will happen after the birth? Now after the birth, what will happen is the flow of the blood will change now. The flow of the blood will change now. Okay, first of all, let me just explain the concepts, and then I will be just writing the things whichever will be necessary, right? So what will happen is the change of the, so let's say this condition is persisting after the birth. Before the birth, that is okay, but after the birth, this condition should not be there. If it is presenting still after the birth, then we will be calling this condition as the ASD or the atrial septal defect. Now what will happen, let's say in this left atrium there is a blood. Now what happens is, the pulmonary arteries will be carrying the blood circulation, right? I mean the pulmonary vein will be carrying the blood circulation. Pulmonary vein will be carrying the oxygenated blood over here. So pulmonary vein will be carrying the oxygenated blood, right? And then what will be happening? Because the blood is actually coming in this direction, right? The more blood will be coming into the left atria. The more blood will be coming into the left atrium. Usually what should happen is this left atrium, blood from the left atrium should go into the left ventricle, and then it should go into the aorta, right? But now what will happen, because this particular defect is present over here, because of this ASD, atrial septal defect, now this blood will actually flow from this region. This blood will actually flow from this ostium secundum and the foramen ovale, okay, whatever it could be. Okay, let's say there is a foramen ovale, so this blood will be actually flowing through this atrial septal defect, and then it will come into this region, that is the right atrium. Then through the right atrium it can go into the right ventricle, and through the right ventricle, that from there it can go into the pulmonary circulation. So that thing is happening over here, right? So let me just write something over here. So what I'm saying is, first of all, that let me talk about the types over here, right? Let me talk about the types over here, right? So if you talk about the types of ASD, right, which they are mentioning about, if they are talking about the types of ASD, then I can write over here that first of all I'm just writing the types, right? So one is the ostium primum, guys, ostium primum. Then there is ostium secundum, right? Okay, these are very common. Otherwise you can see the coronary sinus ASD can also be present. Right, coronary sinus ASD can also be present, okay, which they are mentioned in the textbooks, and even the sinus venosus can be present. But very commonly you are seeing, most common, if they will be asking you, like for example, then your answer should have been the ostium secundum. In this case, this is the most common type of ASD, atrial septal defect. So what is ostium secundum? I already told you, I already explained you over here with the help of this diagram. So as you can see, there is an opening between the septum primum. So this opening, actually this is very common. So this is the most common type of ASD. Ostium secundum is a type of very common type of ASD you will be actually seeing in the babies, right? And then after that there could be the ostium primum, which would be the opening between the septum primum. Now let me explain you over here is that sorry, I mean the ostium primum. Okay, ostium secundum was the opening between the septum primum, and that foramen ovale was the opening between the septum secundum. Now I'm just explaining over here is that was about the type of ASD, and we know that how the flow of the blood can actually change after the birth if the babies will be having the ASD. It will be from left side to the right side, right? And that's what they are actually depicting in this diagram also, the flow of blood. Let's say this heart is actually of a baby who is having a ASD. So let's say this baby is having a ASD, and the flow of blood, as you can see with this arrow, the flow of blood flows from the left atrium towards the right atrium, from the left atrium towards the right atrium. I told you the reason that the amount of blood flow will be actually more in the left atrium. Ideally it should go into the left ventricle, and from there it should go into the aorta. But now because of the more blood, and because of this defect particularly, it will actually leak into the right atrium also, and now right atrium blood will go into the right ventricle, and from the right ventricle it can go into the pulmonary artery, right? Now I'm going to talk about the very particular thing over here. Listen very carefully. Usually what happens is during the expiration, right? Whenever there is a, you are having a inspiration and the expiration. Inspiration means you are inhaling the air. Expiration means you are exhaling the air. During the inspiration, aortic valve and the pulmonary valve, they closes almost simultaneously, right? Okay, almost simultaneously. But during the expiration, physiologically, during the expiration, there is some difference in closing time of pulmonary valve and the aortic valve. So during the expiration, usually aortic valve closes first, and just after some time the pulmonary valve closes. This is happening normally. But let me tell you over here, in the ASD patient, what happens is during the expiration, that closing time is persisting over there, right? So the left atrium will be receiving the more blood and it will be shunted towards the right atrium. From the right atrium, it will be shunted towards the right ventricle. From the right ventricle, it will be shunted towards the pulmonary artery. Now more blood is coming into the right atrium, more blood is coming into the right ventricle. So this more blood will take more time to go through this pulmonary artery. So that's why this pulmonary valve closing time will be increasing now. So delayed closure of pulmonary valve will be seen because more blood was there which was coming from the right atrium, right ventricle, and more blood has to pass through this pulmonary artery. That's why the pulmonary valve closing time will be delayed over here. So delayed pulmonary closing time will be seen during the expiration in the ASD, and during the inspiration also delayed pulmonary valve closing time would be seen in the patients, right? In the ASD, usually the patients will be having, right? In the ASD, usually, just writing over here that during the expiration and during the inspiration events, so that it will be very clear in our mind. So during the expiration, what would be happening, and during the inspiration, what would be happening, right? So during the expiration and during the inspiration, right? So with the red color, I'm just writing this thing. During the expiration, the splitting would be present. So the valve closing time would be delayed over here. So just writing delayed P2 would be seen. Delayed P2 means pulmonary valve over there, pulmonary valve closing time, right? So this is a delayed P2. So over there would be seeing, we will be seeing that splitting is present. Splitting is present over there, right? And even in the delayed inspiration, even during the inspiration, there is a delayed P2 which will be showing the splitting over there. Okay, so I mean normally inspiration, expiration, if you will be comparing like that, normally in the inspiration, right, there is no time gap between the aortic and the pulmonary valve. In the expiration phase, yes, there is, but in the ASD patient, in both the situation, either in the inspiration, either in the expiration, P2 sound will be delayed. Why? Because this valve will be taking much time to close now, because more amount of blood is flowing through that. That is the reason behind that, right? Once we are clear with this, okay, one more thing over here. When the blood is actually flowing from left atrium towards the right atrium, there is not as such murmur present, right? The murmur you will not be hearing when the blood is actually flowing from left atrium to the right atrium. There is no murmur like that. Okay, there is no murmur like that, but continuous flow murmur can be heard when the blood is actually flowing from right atrium to the right ventricle, because more amount of blood is there. So gush of blood will go through the tricuspid valve into the right ventricle. At that point of time, you can hear the continuous flow murmur, right? But when the blood will flow from left atrium to the right atrium, you will not hear the murmur as such. Okay, so that point I had to clear in your mind, right? So once we are done with this, so I'm just writing, okay, a very bold line over here. The bold line is that in the ASD patient, you will be seeing that S2 would be wide and it would be a fixed split, right? It would be a fixed split that will be seen in this particular ASD patient. So wide fixed split you would be seen of S2, it would be seen in the ASD patient. That is the main highlight of this particular topic. Now once we are clear with this one, then let me tell you over here that what could be the association along with this particular ASD. So if you talk about this ASD, it is actually, it can be associated with what? So it is associated with the ASD, it would be associated with, I'm just writing it in the bold letters over here, fetal alcohol syndrome, right? Fetal alcohol syndrome, very important. So it has been seen that it can be associated with the fetal alcohol syndrome. Next thing, that okay, it could be associated with the Down syndrome also, it could be associated with the Patau syndrome also, but that is very important that this could be associated with the fetal alcohol syndrome. That is very important, which you need to understand over here. So Down syndrome, Patau syndrome also association has been seen, but fetal alcohol syndrome is the one which you need to remember. That is very important. Then it would be present at what point of time? Congenital, it is the congenital heart disease, right? So it will be present at the birth. Now usually this is called as the acyanotic heart disease, right? Here we are not talking about the cyanosis and all of those things. This is the congenital heart disease where the patient, right? The patient, you will be finding these kind of ASD patient even in the adult age group, right? So that is also the thing. Now in some patients, the delayed closing can be there of this particular septal defect. In some patient it is asymptomatic also. So this kind of presentation can be there. So even in the adult age group you can find the ASD, right? Okay. Now once we are clear with this, some of the risk factors I would like to mention over here. Risk factor you can mention, like for example in the family history, if you are saying that the grandparents or the father or mother, they were having this particular ASD, let's say, so they might have, their child might have that. So family history is very important. Second thing is as you study in other topics also, the history of the alcohol, smoking, okay, all of those things also, they can also that thing. Okay, so smoking or alcohol, if the mother is smoking or consuming the alcohol during the time of pregnancy, right, during the time of pregnancy, then it is actually increasing the risk of ASD in their child, right, during the pregnancy, obviously, right? Then it is actually increasing the risk of the ASD in their child, right? Then what could be the presentation? Presentation is usually the presentation can be like asymptomatic, as I told you over here, that it could be asymptomatic in some of the child, and later on maybe they might be presenting with some of the symptoms, right? So usually it is asymptomatic in the childhood period, which you need to understand over here. Usually it could be asymptomatic in the childhood period. Then you need to remember that with the large ASD patient, okay, they will not be very comfortable with the harsh physical activities, right? They cannot participate in the marathon races and all of those things, right? So the intense physical workouts, it will be the hindrance for these kind of patients, right? The weight gain will not be that good in these kind of patients, and pulmonary infections might be more frequent in these kind of patients. So this could be the thing which can be present over there. So I'm just writing over here that these kind of patients will be having the exercise intolerance. That is the term. Exercise intolerance can be there, right? These kind of patients might have the poor weight gain, right? Okay, once we have understood this, once we have understood about the symptoms over here, these are particularly, basically these are actually the symptoms of these patients. Now once the symptoms are clear, if you do the physical examination, let's say you want to do the physical examination of this particular patient, obviously you will do. So in the physical examination, what I will find is S1 would be loud, right? S1 would be loud, but there would be, as I said, wide and fixed splitting of S2, wide and fixed splitting in S2. Why it was? Because the pulmonary valve was taking much time, or delayed pulmonary valve closing time was seen in these kind of patients, right? Okay, these two findings are very important as far as this thing is concerned, right? Then for further you can actually go for the imaging exams over here, right? You can do the imaging for this patient. For example, in the imaging, what you will do is, we will start with the normal radiograph. So we'll take the X-ray of this patient. Then you can go for the, if you are seeing that right heart enlargement is seen as such, then you can go for the echocardiography also. So first of all, we are actually going with the radiograph, right? That is the X-ray. And then if you're finding some abnormality over there, let's say there is a right ventricle enlargement. So in some patients you might see that right heart enlargement can be there, right ventricular enlargement can be there, right? Why? Because gush of blood was coming from the right atrium into the right ventricle, because you remember that from the left atrium the blood was going into the right atrium, and then from the right atrium the blood was going into the right ventricle, right? So because of that, right ventricle enlargement can be there. And moreover, because the right ventricle is carrying more amount of blood, so it would be having problem, it would be taking more time, I would say it would be taking more time to actually excrete through the pulmonary valve. So that's why delayed pulmonary closing was also seen over there, delayed pulmonary valve closing, right? Okay, once we have understood about this one, then we can actually go for the echocardiography. You know that echo is best for diagnosing the heart diseases. So echocardiography can be done over there. In the echocardiography, what could be the finding over there? You can find the right atrium enlargement sometimes, and this could be a thing. So I would just tell you, I would just show you over here. So right atrium enlargement can be seen over there. So I'm just showing you the echocardiography image over here. As you can see in this one, this is the left atrium and this is the right atrium, and you can see very clearly that there is a, with the cursor I will try to show you, yeah. So there is a defect in the wall, there is a defect in the septa of the atrium, between the atrium. So this is the interatrial septal defect, right, ASD. So where the blood can actually move from the left atrium to the right atrium, right? That is the problem which you can see in the echocardiography. So very clear image you can see in the echocardiography, right? Okay, differential diagnosis, you might heard that VSD could be the differential diagnosis for this kind of patient. And let me tell you, let me come to the complications part, and then we will be talking about the treatment part. So complications, if you will be talking about in this patient, complication might be same as the as we had a talk about in the ventricular septal defect also. So like heart failure could be there in some patients, emboli can be actually formed over there, right? So these can be some of the complication which can be seen in these kind of patient. But as far as treatment is concerned, right, as far as treatment is concerned, so there is a very interesting treatment for this kind of patient, right? Because if these kind of patients are coming, you are finding these kind of patients, so usually we can actually manage smaller ASD, we can actually manage with the medical treatment, and larger ASD obviously we need to go for the surgical management. But there is one thing that, okay, that if you want to do the medical management, right, for the smaller ASD, then for the medical treatment per se, what you can do is you can actually try the digoxin, or you can try the furosemide, right? So digoxin or the furosemide can be given. But if you talk about, I would tell you something now over here, right? For the larger ASD, you have to go for the surgical management. So let's say if the ASD size, right, there is a defect size is there, that defect size is less than 8 millimeter, right? What I'm saying is, for the surgical management, I'm talking about this thing, right? For the surgical management, right? If you have to do the surgical management over there, okay. So if they are saying that, what they are saying is that if the ASD size is lesser than 8 mm, right, and with that the patient is asymptomatic, or the patient is asymptomatic, right, then in those cases you will be actually not doing anything over there. You will not intervene in this patient. We will be waiting for some time, right? So wait and watch approach would be there, because in some patient the closure time of the defect might be longer. So with that, we'll be actually wait and watch for that particular part. So in some patients, within about 6-7 years, it will spontaneously close on its own. So what we will do is, we will not do anything in such patients. Actually, usually it can actually undergo the spontaneous closure within 6 years, okay, within 6 years. Let's say if the ASD size, is more than 8 mm, right, or let's say the patient is symptomatic now, right, then what you will do? Or they are saying that the ASD is lesser than 8 mm, ASD is lesser than 8 mm, but at the same time they are saying that it is persisting for more than 6 years, remember less than 6 years, if it had to close spontaneously, then it could have been closed in less than 6 years, but if it is persisting more than 6 years, right, then we need to actually think of the surgery in this case. Then in these cases we will be thinking of intervening in these kind of patients, we'll be thinking of surgery in these kind of patients in these scenarios only. Otherwise, if the patient is lesser than 6 years, or if the patient is having lesser than 8 mm size of the ASD, we'll actually wait and watch for those kind of patients, right? So in this case, what we will do is we will go for the surgical management, right? In this case, we will go for the surgical management. I mean, you will be actually taking the patch and you will be applying that. Okay, what we had actually already talked about that in the VSD also, that patch closure might be done over here in this particular defect, right? So that was about the atrial septal defect. Okay, how the patient might present to you, how they can actually make a question over this one. They can actually make like a 35-year-old man presented to your clinic and for a routine physical checkup, and they will be saying in last few years the patient was actually not very serious about their medical checkup and all, and he was not having any kind of complaint also or something like that. You did the physical examination and you thought that you are actually doubtful about a new murmur over there. Now out of nowhere you are actually hearing about the murmur. Okay, so obviously you will be confirming yourself, and then they are mentioning about a wide fixed split S2 heard sound. If they will be mentioning about this word, wide and fixed splitting of S2, then definitely they are actually talking about the atrial septal defect in this case. So the highlight of this topic is the finding, very peculiar finding which I told you in this particular discussion, is that there is the wide fixed split of the S2 heard sound, right? And the reason I have told you at the same time that the delayed closure of the pulmonary valve is the reason behind this wide fixed splitting of the S2 heard sound, right? So I hope you enjoyed the discussion over here, and I would like to thank you for watching this one till the end. So I will see you in the next one. Please make sure that you like, subscribe the channel, and share as much as possible. Thank you so much for joining in, and I will see you in the next one. Bye bye, take care.